Good evening, everybody who are watching this program from India, and good morning to those who are watching it from the United States. Welcome all of you to the live program number 132 at Orthopedic Principles. Today, our guest of honor is Distinguished Faculty Professor Dane Wukich. Professor Wukich is a professor and chairman of the Department of Orthopedic Surgery at the UT Southwestern, where he holds the Charles Gregory Chair in Orthopedic Surgery. He's also the Medical Director of Orthopedic Surgery at UT Southwestern Hospitals. Professor Wukich spoke on ankle fractures in diabetics, calcaneal fractures earlier with us, and today Prof. Wukich will enlighten us on diabetic foot ulcers and infections. So today it's my great honor to have Professor Wukich back with us. Over to you, Prof.
Thank you, Professor. So today I hope to give you an overview of diabetic foot ulcers and infections, particularly as it applies to orthopedic surgeons. So we look at diabetes and amputation, and it's truly a global problem that's getting worse every year. And it's estimated that somewhere in the world, a limb is lost every 20 to 30 seconds as a consequence of diabetes. Following an amputation in patients with diabetes, about a third of those patients will lose their contralateral leg in 3 years, and about 50% of them will die within 5 years. We actually looked at a group of patients and we queried them to try and figure out what their biggest fear. And the interesting thing is when we ask our patients with diabetes who had foot-related complications what they feared most, it was interesting that they reported to us that they feared losing their leg more than they feared dying, which is a very interesting process. Now, the 5-year mortality of diabetic foot disease, if we look at it in the context of cancers, you can see on the left are some common cancers with a good prognosis. On the right, you have lung cancer and pancreatic, not so good. But what's interesting is that diabetic foot disease, to include ulcers and amputations, are worse than many common cancers with regard to a 5-year survival. But unfortunately, patients, I think largely because diabetic foot problems don't cause pain, don't think of this in this way. But I think we have to recognize that a foot complication in a patient with diabetes is a surrogate marker of underlying illness. Foot ulcers in the United States, approximately 2% per year, may be as high as 4% per year. And we have certain populations that are at high risk, and those include our patients of Hispanic background and patients who are military veterans. It's estimated that 1 in 6 to 1 in 4 patients will develop a diabetic foot ulcer during their lifetime. And once you develop an ulcer, your risk of amputation goes up by 800%. And we know that ulcers precede amputations 85% of the time. So most of the time that a patient is going to end up with an amputation, it's going to be because of a pre-existing ulcer. Now, if you look at a global perspective of diabetes in the world, this is a chart that I got off of the internet last night, that China has about 116 million people with diabetes, India 77 million, United States 31, and Pakistan about 19 million. So if we were to look at this population and calculate that 2% of these patients with diabetes are going to get an ulcer in a given year, you can see that in China, that's over 200,000. In India, it's 150,000. United States, 62,000, and in Pakistan, nearly 40,000 diabetic foot ulcers per year. So this is not an uncommon problem in the countries that have high rates of diabetes. Roger Pecoraro came up with what he called his Triad that was published in 1990. And it was minor trauma that you might get from wearing a pair of shoes that don't fit or injuring a toe or a foot, and you get an ulceration. And in the presence of faulty healing, this leads to amputation. So we have to figure that everything is going about. It doesn't have to be major trauma. It doesn't have to be a major wound, but in patients that have impaired healing, they can end up with an amputation. There are systemic and local factors. As you can see on the left, there are systemic factors of hyperglycemia, peripheral artery disease. Patients who have blindness will oftentimes injure their foot. If they have chronic renal disease, they may have poor bone quality and impaired healing. Then there are local issues like neuropathy, structural foot deformity, trauma from improperly fitting shoes, and callus formation. And these are the things that we as surgeons can address. High-risk zones for ulceration underneath the hallux and the first and the fifth metatarsal head. And as you can see here, if you get a hammer toe deformity, you get pressure at the tips of the toes underneath the metatarsal heads. If you have bunion deformities, you can get pressure from interdigital. So we as surgeons have to look at these carefully for these high-risk areas and be thinking about ways that we can reduce these risks for ulceration, be it surgically or be it offloading. Now, the forces that act on the foot cause wounds, and there are basically two types of forces, but the geometry of the wound will tell you what type of force is at work. These two forces are sagittal forces and what we call shear force. And shear force can be in the transverse plane or it can be in the frontal plane. Peak pressure is most understood. That's like our ground reactive pressure that we always talk about. It's the peak plantar force that a patient gets from walking on the foot. During the gait cycle, it starts in the heel and then advances towards the forefoot. And when we have toe off, the forefoot is at high risk. It's easy to measure. It's been studied very, very well. And it's similar to the ground reactive force that we as surgeons are all familiar with. But shear force is less well understood, but I think equally important. It's in the transverse and the frontal plane. It's between bone and the soft tissue, and also between the soft tissue and the shoe. And it's harder to measure than peak pressure. But I always like to think of it as a friction. It's what causes blister on the bottom of a foot. And this is an example of a patient moving on a board, but you can see the shear force that's acting. And this would be the same thing inside of a shoe, because even when we have a shoe on, there's motion between our foot and the shoe. There are many biomechanical forces acting in different planes on the foot. We have a foot here that had a Charcot deformity reconstruction. You can see that you have a vertical force, you have a longitudinal force, you have a rotational supination or pronation force, and then you're going to have a shear force on the bottom of the foot. Now, sagittal plane forces are most commonly manifested in reduced ankle dorsiflexion. We get with ankle equinus. That increases the plantar pressure, particularly in the forefoot, and that results in diabetic foot ulcers. It can also contribute to a midfoot Charcot. And this is an example on the right where you see a normal foot with not a tight Achilles tendon versus a tight Achilles tendon, and it loads the midfoot, resulting in increased plantar pressure on the forefoot and stressing the Lisfranc joint. Peak plantar pressure here illustrates with an ulcer underneath the first metatarsal head, as you can see. And if you map this out with pressure, you can see that red area that demonstrates a very high area of pressure compared to the contralateral foot. When you see a circular wound like this, that tends to be from peak plantar pressure, and very, very well-defined wounds like this. On the other hand, shear force usually have an oval type of wound or elliptical. And the cause of this is a rubbing. It's a classic blister. It can be from poorly fitting shoes. And I've actually seen it from dressings that get put on that can be tight or even loose that can cause this shear force. We have to be very careful in a patient with neuropathy when we put on cast and we put on dressings. When you document a foot ulcer, it's important to document certain things in every one. You look at the dimensions. You have to document the length, the width, and the depth. You have to look at the wound bed. Is it granulation? Is it fibrous tissue? Is it infected? And as you can see on the right, that wound has 100% granulation tissue. Finally, you look at the peri-wound tissue. Is there an associated cellulitis? And lastly, we want to check to see if the wound probes the bone. If it probes the bone, then there's a chance that it could have an underlying osteomyelitis. When we look at a wound to characterize as an infection, we actually look at signs of inflammation. Obviously, redness or rubor, edema, tumor, warmth and calor, indolor and pain, or frank pus. If we have 2 or more signs of inflammation or frank pus, that is equivalent to infection according to the Infectious Disease Society of America. Now, remember that some of our patients have profound neuropathy and won't manifest pain, but redness, warmth, edema, etc., make you think that an ulcer is infected. You have to beware in certain instances. In this particular case, you can see that this patient has an extruded talus, but did not have any pain. And diabetes patients are obviously sometimes immunosuppressed because of their glycemia, and they may not manifest fever, elevated white blood cell count, or pain because of the neuropathy. The earliest sign of an infection in a patient with a diabetic foot wound may be unexplained hyperglycemia. They're normally well controlled, and suddenly for the past few days, they haven't been able to control their sugars. And finally, I always like to teach people about the diabetic flu. In a patient with a foot wound who experiences symptoms of nausea, vomiting, or anorexia, always think about the possibility of an underlying diabetic foot infection. The key thing is you have to have a high index of suspicion in these patients because they may not manifest the classic signs of infection. Now, classifying diabetic foot ulcers is useful. The original one was called the Wagner classification, and it went from 0 to 5, and you can see that grade 0 was a pre-ulcerative lesion, and grade 5 was a gangrene of the entire foot. So grade 1 was a superficial ulcer, grade 2 was a deep ulcer. Neither of those were infected, and then infection started with grade 3, grade 4, and grade 5. Very widely used, often cited in the literature, but it has some limitations. The downside to it is it doesn't talk about the degree of ischemia, only when they reach gangrene. Well, you know, for patients to get gangrene, they have severe ischemia, but many of these patients have impaired perfusion and not gangrene. And it doesn't include infection until grade 3. The University of Texas classification from San Antonio was published and really incorporated a lot of important things. As you can see on the left, they staged patients whether they had an infection or ischemia. And then they also described the wound based upon the depth. And then they put it into a staging and a grading situation, as you can see on the right, and they could classify the wounds based on the presence or absence of infection, the presence or absence of ischemia, as well as the depth. And I have found this very, very useful. And the reason I find it useful is that if you look at increasing severity as you go from a grade 0 to a grade 3 wound, you can see the black line that the increased rate of amputation. So severity of a UT San Antonio classification correlates to a higher risk of an amputation. And you want any classification system to be able to provide you with clinically meaningful data. So what about comparing the two? The UT classification is more descriptive. Its increasing severity is associated with an increased risk of amputation, and it has greater prediction of ulcer healing. But despite whether you use the Wagner or the Texas classification, both show that as the severity increases, you have lower healing rates. And that's an important thing to recognize, that we want to really get these patients before infection or ischemia can set in. So the treatment of diabetic foot ulcers is pretty standard. We want to offload them, we want to do sharp debridement, and we want to apply moist wound care. When you do most of these simple things, you can actually heal most ulcers. So here's an example of a patient that came to me with a chronic wound, 6 or 8 months, had really done nothing, and this patient was a nurse. And so you really can't tell what's underneath that callus. So the first thing you have to do is debride that wound and convert that chronic wound to an acute wound, as you can see. I was very comfortable at this point in time that there wasn't an underlying infection present. I got rid of the callus, and by reducing the callus, you reduce the pressure. And this same person, just after 2 weeks, I saw him back after one debridement and offloading in a boot. He almost healed, despite the fact that he had been having this for 6 months. Some simple measures allowed this to heal, essentially. If it doesn't heal within that simple time period, then you can look at total contact casting, which was popularized in India in patients with leprosy by Dr. Paul Brand. And we've also added Achilles tendon lengthening to it in patients who have an equinus. By adding an Achilles tendon lengthening, you can decrease the forefoot pressure. The cast will also redistribute pressure to your hind foot. You temporarily weaken plantar flexion, which reduces pressure on the forefoot. And then finally, you keep the cast on for 4 to 6 weeks. And it allows that wound to be offloaded quite nicely. The healing rates, if you look at people that have had a total contact cast and an Achilles tendon lengthening for forefoot ulcers, had a 100% healing rate. If you just used the total contact cast, it was about 88%. Very, very high healing rates. But the interesting thing is that adding an Achilles lengthening decreased the risk of recurrence by a factor of 4. And at the 2-year follow-up, they found that 81% of the patients who were in a total contact cast recurred, but only 38% of the patients with an Achilles tendon lengthening recurred. So that's a 52% reduction in recurrence using the TAL. And beware of over-lengthening the Achilles tendon. It's happened to me. If you do this, you can create an iatrogenic heel ulcer, and that can be a very, very difficult problem to heal, oftentimes more difficult than the first Achilles tendon lengthening. An interesting thing is selective plantar fascial release. This was a study out of Korea, and they looked at patients who had forefoot ulcers. They did a very elegant dissection, as you can see, of the plantar fascia, and found that plantar fascia inserted to each of the 5 toes. And the goal was that if you had a reduced dorsiflexion of the metatarsal phalangeal joint, you could get an ulcer, and their goal was to increase that dorsiflexion by transecting only the fibers going to the affected toe. So here's how they did it. They actually did it under local anesthesia. They could palpate the plantar fascia, and then they would cut only the fibers going to the hallux. As you can see, there's an ulcer here. And so this was an example of the patient before, and you can see that it recovered very nicely because they increased the dorsiflexion of the hallux. The stairway to limb loss is important to understand. That if you look at mortality in Native Americans in the United States, if they had a toe or a foot amputation, approximately 40% died. If they ended up with a transtibial amputation, about 45% died, but nearly 2/3 of the patients who had an above-knee amputation died. And so this stairway to limb loss begins with a foot ulcer in the forefoot. Sometimes the patient then requires a transmetatarsal amputation. That may not heal, so they end up with a more proximal foot amputation, then a below-knee amputation, and then, of course, an above-knee amputation. And as you can see from the numbers, a high number of these patients who undergo an above-knee amputation will die within a period of time. So we must change our thinking. Limb salvage, really, we have to change and think more about preserving limb function. Sometimes preserving a limb that is poorly functioning is not good. And if patients have the ability to have a well-done amputation and can get a prosthesis and be able to ambulate, that's very, very important and will be much better. So I think we have to get away from the fact that, oh, we saved the foot, but if it's non-functional, what good is it doing to the patient? The team leader must have passion. It really doesn't matter who the team leader is. It could be anybody in this particular group, but you need to have a whole host of people involved in the care of the patient with diabetic foot. In some places, you have vascular surgery. Other places, radiologists or cardiologists will do interventional procedures. You have to have good medical consultants. You have to have good nutritionists, and you have to have hospitalists in internal medicine who will help you when they're sick. And then you have to have a surgeon who is interested in the diabetic foot. It's a lot of work, and not a lot of surgeons want to do this, but it's very, very rewarding. So I think the key thing is we want to look at saving the limb because we can save a life. Saving the foot is the highest priority. A partial foot amputation, such as a toe, is better than a foot. And we want to avoid or reduce the above ankle amputations, because we know that the highest ambulation will be in somebody who has a foot preserved that's functional. Even a partial foot amputation will result in a high likelihood of ambulation. And finally, above ankle may not result in much way of ambulation. And the reason for that is very simple. If you look at the energy expenditure after an amputation, with normal gait being 100%, you can see the increased energy expenditure required as you go more proximally. You can see that a patient to walk with crutches, three-legged gait, is almost the same as an above knee amputation. So we really want to keep our patients in the category of, foot amputation at the most a below knee amputation, because our patients may not have the myocardial reserve to increase this energy expenditure to allow them to ambulate. If they can't ambulate, their cardiovascular condition deteriorates and they end up having higher morbidity from cardiovascular disease. I think the key thing to remember as surgeons, we can look at osseous reconstruction, such as removing bone, exostectomy. We can do osteotomies to correct deformities. We can do an arthrodesis, and then we can do an amputation, but it should be a functional amputation to restore the ability to ambulate. And that really works on correcting the sagittal force corrections. Tendon rebalancing, on the other hand, is important. We may lengthen a tendon, we may transfer a tendon, we may just completely cut the tendon. And that can actually help both sagittal forces and shear forces if patients have overpull of one muscle or another. The goals of osseous reconstruction are to remove or realign bony prominences. You can see a patient here that has a large plantar ulcer, and we want to achieve a stable and a plantigrade foot, and so that patient can be able to wear a shoe or a brace, and we want to preserve a recurrence. So in this case, we actually went in and did an exostectomy on this patient, and you can see on the right how nicely the patient healed without any fancy plastic surgery flap. Just by removing the bone and letting Mother Nature heal this, it healed very nicely. Sometimes in Charcot feet, we have to address the biomechanical deformity. As you can see here, you have an extruded navicular, you have a sagittal plane deformity with pretty much collapse of the longitudinal arch. And in this case, these can be significant problems. The talus is declined plantarly, and that you lose that normal relationship. And we reconstruct this, and 3 months later, the patient has a solid, well-balanced foot. Forefoot reconstruction can include arthroplasties of the digits. Sometimes removing a toe is necessary, sometimes correcting a hammer toe deformity, sometimes doing a tendon release. Fixing the bunion can help. Doing arthrodesis of the hallux can help. Sometimes you have to remove the metatarsal heads, much like we would do in a patient with rheumatoid arthritis. And then sometimes we maybe do a functional amputation. And this is an example of a person that I treated who had diabetes, profound neuropathy, very severe cardiac disease, needs a cardiac transplant, but he can't get on the list. He also has a renal disease and needs that transplant. And the transplant team wanted his feet to be clear of disease. And so he was absent sensation, but he had good pulses. And this is what his foot looked like. He had a callus, but once you debrided the callus, you found that there was that frank ulcer under there. So the question is, I had a gentleman that really was in need of a cardiac and a renal transplant. And what did I want to do? I looked at his x-rays, and his x-rays were surprisingly not bad, but he had this diffuse callus. So I elected to treat him with a pan-metatarsal head resection, simply taking out his metatarsal heads, doing what we call the Hoffman procedure. And I did it from a dorsal approach. And, in about 8 weeks, he still had some callus, but all of his pre-ulcerative lesions had actually healed very nicely, and he could get on the transplant list. Here's another example of a patient with a left hallux ulcer. Quite honestly, you can see from this, according to what I've already described, there's an infection here. There's cellulitis that is extending more than 2 centimeters proximal. There's clearly soft tissue swelling, and he's got a wound there. 59 with diabetes, but the thing that caused this wound is he has marked limitation of motion of his hallux MTP joint. His pulses were normal, absent protective sensation. And you look at his x-ray and he has end-stage severe arthritis. So because he didn't have the ability to move that joint, he kept jamming it and ended up with an ulcer that became infected. And so when I saw him, I debrided the ulcer, I converted it to an acute wound, treated him with some antibiotics. He started to improve. His active range of motion, as you can see, was very limited. And I knew that I could get the infection cured. I could probably heal the ulcer, but the recurrence rate was going to be high. And so you look at his passive motion, virtually significantly limited dorsiflexion. So in this gentleman, I did what we call a Keller arthroplasty. I resected the base of his first proximal phalanx and intraoperatively got about 45 to 50 degrees of dorsiflexion. This is just ranging the motion intraoperatively. And you can see on his 6-week follow-up, he healed his wound, still has some edema. But the key thing is his ulcer completely healed and his chance of a recurrence is significantly low because of the range of motion. You can see all of the callus that he had preoperatively, and now virtually all the callus has resolved. And this is another case that will illustrate the importance of a diabetic foot wound. This is a patient with type 2 diabetes, end-stage renal disease, with hypertension, and also coronary artery disease, and was awaiting a reconstruction for her Charcot foot. And you can see there's a large callus there. Underneath it, you could probably say there's a very small wound, but she has a non-plantigrade foot. Her area is, because of this area underneath the cuboid, she's developing that callus and frankly a wound. So this was a good candidate for a Charcot reconstruction. But a few days later, while waiting for the reconstruction, she started to complain of increasing pain. She had chills, she had fatigue, she had the diabetic flu, as I talked about. And she had a small amount of wound drainage, but she went to the emergency department, her white count was 29,000, and you can see the size of her left lower extremity compared to her right side. So now this is a patient who is manifesting severe signs of an infection with fever, fatigue, diabetic flu, and a very high leukocytosis. And that was the appearance of that ulcer. Really didn't change much from the presentation when it was in the office. But if you look at her radiographs at that time when she came in, she's now got gas in her foot that's escalating up the leg almost to the level of her knee joint. Severe infection with necrotizing fasciitis, ended up with fasciotomies, and you can see the condition of her foot. Went back and ended up having an ankle disarticulation. Colleague of mine tried to get some closure. Ultimately, she needed a transtibial amputation, which I did. I had to be creative with my flaps because of the fasciotomies. But ultimately, we were able to get the wounds to heal. And if you can see, here she is, ended up going back to work eventually and actually doing surprisingly well, despite having an infection was not limb-threatening, but life-threatening. And so she almost died and was in the hospital. Oops, sorry about that. So I think the key thing is to identify the biomechanic etiology of why wounds occur. It's not just good enough to get the wound to heal because we know that they'll recur 70% of the times. Sometimes you have to do an osseous reconstruction to address sagittal force and peak plantar pressure. That includes the exostectomy, the arthroplasty, the osteotomies, and the arthrodesis. And sometimes a functional amputation, as you just saw. Other times, tendon rebalancing becomes very important in addressing the sagittal force correction as well as the shear, and that can include your lengthening, your tendon transfer, your tendon releases. Remember that limb-threatening diabetic foot infections. This is very important. When you see somebody who has cellulitis more than 2 centimeters from the ulceration, if they've got constitutional symptoms of fevers and chills, sweats, etc., if they have lymphangitis, if they have hyperglycemia, if they have ischemia and they probe to bone, always think that this is a limb-threatening infection. And always remember that patients with limb-threatening infections are at risk for dying. These can result in significant mortality in patients who are sick. So in summary, I would tell you that diabetic foot disease is a serious problem. It's associated with a high mortality at 5 years, high morbidity resulting in amputation. It's increasing in frequency, as I showed you the numbers in China, in India, and the United States and Pakistan. And the key thing to take away is we as physicians have to have a high index of suspicion in these patients because oftentimes they may not manifest the traditional signs of illness. And remember, they may not have pain. When you see pain in a patient with a diabetic foot ulcer, always be very suspicious because their neuropathy usually masks pain. If they don't have systemic signs, you still have to have a high index of suspicion. So the 6th century philosopher Lao Tzu always said that a journey of 1,000 miles begins with a single step. And so diabetic foot disease is really taking baby steps. It's in its infancy, but hopefully with more people becoming interested in this, we'll be strolling and cruising in the very near future, like my granddaughter at 3 months. And then she's learning to golf, and now she's learning to ride horses. With that, I thank you, and I'd be happy to take any questions if there are any available.
Thank you very much, Professor, for that brilliant presentation of yours, as usual. A few questions. Can you provide us a few tips and tricks for a good total contact cast? Because sometimes we often find that you need the order, the bad order that comes in from a cast, and how frequently we need to change the cast. And is there a contraindication for using a total contact cast?
I think infection is a contraindication for a total contact cast, but I think the tricks about putting on a total contact cast, number one, you have to have somebody experienced. Number two, the traditional total contact cast has little in the way of padding because it was meant to transfer the force from the cast to the foot. I think that you should never stop at the MTP joints like we might do with a traditional cast in a patient. You have to extend past the toes because otherwise the toes will flex and extend in the cast and cause ulcerations. I think the key is really to pad it appropriately, to pad the shin, the tibia, and also pad over the malleoli in particular. And I also like to really pad the arch if I can. As far as how often to change it, my first cast, I usually will change in about 4 days. And the reason for that is there's usually a rapid resolution of edema in a total contact cast. And then they can develop those shear forces. Once you start to get stability, then you can probably go to every week or every 2 weeks in a total contact cast.
The other thing is, when you say a total contact cast, it's completely covered, isn't it? You don't give any scope of, any air circulation to go inside, isn't it? Other than from the proximal part.
That's the classic way to do it. You cover the toes. I think it's okay to leave the toes open if you want, but you have to extend your plaster or fiberglass beyond the toes so that those toes don't flex and extend because I've seen iatrogenic ulcerations from that. Total contact casting is actually very safe when done properly.
I think it is one of the, I would say it's the workhorse for treating a diabetic foot, isn't it?
I would agree that it's the workforce for foot ulcers. It's the workforce if we do a Charcot reconstruction, if we have an ankle fracture afterwards, to put somebody in a cast like that. Anybody with neuropathy, I think it's the workhorse. And quite honestly, it's very, very underutilized. In the United States, they did a study and they looked at all the wound centers, and they found that only 2% of wound centers used a total contact cast for offloading. And in my opinion, the reason they don't use it is people get paid more to sell a boot and put a boot on than they do to put a cast on. And the cast takes some time, but a cast well done is a very, very good option. And like I said, it really has its origins in your country when Paul Brand worked with his patients with leprosy, and he brought that to the United States and diabetic foot problems.
Prof, just an extension of that question. Suppose if there's an infection, like what you said that there's a contraindication to put a cast. And suppose there's some mild infection, you do an office debridement, like you said, and then shall we put on to a total contact cast immediately?
I think if it were truly a mild infection and you were comfortable and you advised the patient, you could do it. I think you have to be careful though, because remember, those patients may not have pain. Sometimes if in that case, I would prefer the ability to look at the wound. I don't like windowing total contact casts like we would do in other casts. But if it were truly a mild infection and you were going to see the patient back in a few days, I would consider doing that. But again, if I had the option of some other form, I probably would do it that way.
Prof, Senthil is also in our Zoom room, and Senthil, your questions to Prof.
Dr. Wukich, thank you. Thanks for taking up this topic. This is the major problem all over the world, as you mentioned it. So between the ulcers in the forefoot, here, midfoot, and heel, which one has a higher risk of amputation? You know, like the forefoot ones or the heel ulcers?
It depends
which
on
one you get to.
Depends on what you mean, Senthil, because in the forefoot, you might take a toe off just because it's easy. But the ones that associate with major amputations, it would be the heel, the hind foot, for sure. And the reason is hind foot ulcers are much more difficult to treat than forefoot. A total contact cast offloads the foot, but it actually transfers forefoot pressure to the hind foot. So it's a difficult thing to offload a hind foot. So I think hind foot ulcers are almost always associated with major biomechanical problems, such as osteomyelitis of the calcaneus or a bad Charcot. But the forefoot, I think, is much easier to treat and heals much higher. And I think the key thing that I would say, Senthil, is, the rate of amputation, if we could reduce the rate of major amputation by doing more minor amputations, that wouldn't necessarily be a bad thing. So if you took a toe off, people can do fine with a toe. A well-done transmetatarsal amputation, as you know, some of our patients in Dallas, and I'm sure a lot of patients in India, can't get a prosthesis for monetary reasons. But in a well-done transmetatarsal amputation, they can ambulate really well. But the moment you go above the knee and they can't get above the ankle and they can't get a prosthesis, they're relegated to being on crutches or not walking or in a wheelchair. So to me, I think that ideally we want to avoid amputations, but if we increase the number of toe amputations and transmetatarsal amputations and we saved reducing major amputations, I think that would be a big, big thing for society in general.
Another question is, in the US, the wound care is taken care of by the wound care specialist, but in a lot of other countries, the orthopedic surgeon or whoever the treating surgeon is involved in the wound care. So can you give some nice tips and tricks or your preferences for wound care after you convert it into a wet wound, like an acute ulcer?
Sure. So I think the first thing is always remember the basics. And what I showed you, the standard of care, the basics are three things. Number one, it's offloading. Probably that's the most important thing. Number two is to convert a chronic wound to an acute wound by debridement. As surgeons, we do that best with a scalpel. Thirdly, you want to allow moist wound care. And I think that one of my teachers and friends, Larry Harkless, always said, it's much more important what you take off of the wound rather than what you put on it. There are a lot of fancy dressings, but the bottom line is debride the ulcer, offload it, and good wound care. Now, the thing what we've learned is at 4 weeks, if you do that and you haven't reduced the area by 50%, then you probably need to think of something else to do. What's the biomechanics? Why is this wound not responding like it should? Do they have a tight Achilles tendon? Do they have metatarsals that are prominent? Do they have restricted motion of their hallux? Do they have a Charcot deformity? So the real pearls to me are, number one, really get good at offloading with a total contact cast or a boot if you're comfortable. Really good at debridement, because I think debridement is really, debridement, it converts that wound. These wounds have high MMPs, metallometal proteases, that are impeding wound healing. They have this chronic state of inflammation. By debriding them, we get rid of those MMPs and we allow the granulation tissue to start. And then finally, good moist wound care. It can be simple as a hydrogel, water gel. You don't need fancy dressings. And I think you should see the patients. You need to take pictures. I think that's an important thing to monitor them. Make sure that they're peri-wound area. And the other thing which I didn't mention, which I think is very important now that I'm thinking about it, when you initially assess patients for their wound, number one, you document the presence or absence of neuropathy. Most of them are going to have it. But also very, very important is you've got to document the presence or absence of any peripheral artery disease. And they may have pulses, but I think it's not a bad idea to do some study to characterize how good their flow is, their ankle brachial index, their toe brachial index. I also think it's important to have great glycemic control. If their hemoglobin A1C is 12, that's going to cause a chronic inflammatory state. And finally, the thing that I think is also underestimated is nutrition. Just because somebody is overweight doesn't mean that they're well nourished. They can be poorly nourished and still be overweight. And so I think we have to look at their albumin, their pre-albumin, if you will. Some places you can't do it. So I think it's very important in an initial assessment: neuropathy, peripheral artery disease, deformity, glycemic control, nutrition. And then you characterize there's no infection. If there's no infection, that's a good sign. And if you can think of anything else that I missed, let me know.
Infection, when you have an infection, like I've seen you getting very aggressive about, going in, debriding and antibiotic treatment. So what's your protocol when you see a forefoot ulcer with a kind of a infection with raised inflammatory markers, so?
Sure. So the way I look at infections, and the Infectious Disease Society of America characterizes them in the mild, moderate, and severe. A mild infection, less than 2 centimeters of erythema, and there are no systemic signs whatsoever. Moderate infection is more than 2 centimeters of peri-wound inflammation, erythema, no signs of systemic. And then severe are people that have systemic signs: leukocytosis, tachycardia, respiratory rate, etc. If somebody has a mild infection, I'll debride the ulcer, make sure I'll probe the bone, see if there's any, get an x-ray, and I'll treat them with an oral antibiotic and follow them closely. They should respond very quickly. About 50% of moderate infections you can treat in the outpatient setting in a similar way, but about 50% of them will end up requiring admission. Interestingly, that in my own study that we published, 5% of patients with a moderate infection ended up having a transtibial amputation. 5%, 1 in 20. Severe infections all need to be hospitalized from the get-go. They need to be aggressively treated, antibiotics, glycemic control. Sometimes they're very ill, as that last patient I showed you, and they almost all require some form of urgent incision and drainage. The rate of major amputation in my series, if you came in with a severe infection, was 19%. So it was much higher. So moderate infection that's got no systemic signs, try outpatient. Severe infections, get admitted. And I also believe strongly that infections, unfortunately, come in and they get admitted to the internal medicine service and they don't tell us about them for 2 days. I think, quite honestly, we should know about them right away. I liken a diabetic foot infection to a myocardial infarction. Within 90 minutes, they're in the cath lab if they have ST elevation, because ischemia. Time is tissue. If you have trauma, it's that first hour golden rule. A diabetic foot infection with a severe infection, that's something that needs to go urgently. And obviously you have to assume they have a full stomach because they have gastro, but I don't think that we get notified about them. It should be our decision whether or not to go to the OR. Don't wait for a day or two to tell us that. So every place that I've worked, I've tried to get the medicine people, hey, let us know about all these infections. Let us make the decision, because I think the earlier you go in, number one, you may save a part of their foot, or you may not have an amputation, but you may end up with a minor amputation as opposed to a major amputation.
That's great. Thank you. Hitesh, I don't have any question. Thank you very much, Dr. Wukich.
Thank you, Prof. Wukich. I think there are no more questions. Thank you, Prof. Wukich, for sparing your valuable time with us. It has been such an enlightening experience for the last 3 lectures, including this one. And all our audience, always they look forward for your lectures, and I'm sure you'll be able to enlighten us with a few more lectures in the future.
Well, thank you very much, and it's been a pleasure.
Thank you, Prof.
Thank you, Doctor.
Thank you.
Thank you, Dr. Wukich. Bye-bye. Thank you, Hitesh.